With introductions, we want to apologize to folks for a little bit of confusion in the beginning. We do have our first national prep webinar today, so we're glad to have everybody with us. Today, we're lucky enough to have Dr. Alan McGuire, who's a research scientist with the Veterans Administration HSR&D Center for Health Information and Communication, Indianapolis, Indiana. And he is also a colleague, I should say, who has worked on research around illness management and recovery with our very own Tom Bartholomew. So we're really excited to have him here, and he has a lot of information to share with us around evaluation of recovery-oriented acute inpatient mental health care, a topic very fitting for our state hospital staff. So with that, Alan, I want to welcome you and turn it over to you.
All right. Thank you, Dawn, and thank you, Tom, for the invitation. I'm glad to be here with you all today. And hopefully, yes, there we go. Okay. So first of all, the obligatory disclosures. So I'm bound to say that these are my views and don't reflect anything that the Department of Veterans Affairs or the U.S. government has to say about anything. And I have no financial conflicts of interest to disclose. Also, I'd like to acknowledge, as you can see, the very robust study team that was involved in making the research that I'm about to present on happen, as well as my funding from the VA Health Services Research and Development. You can see the grant number there. So today I'm going to talk to you about, as Dawn said, recovery-oriented acute inpatient mental health, in particular my RAIN-MH study, and we're going to get into the operationalization of recovery-oriented inpatient care, its penetration within the Veterans Health Administration, the relationship between recovery-oriented inpatient care and patient outcomes, and finally touch a little bit on the implementation process. So a little background here. So as many of you, I'm sure, are aware, mental health systems have sought to transform services from more medical models to recovery-oriented care that embraces the patient's role in defining and achieving treatment success. So literature has linked recovery-oriented care to increased function and clinical outcomes, but that research has really been done in outpatient mental health settings. And there's really a lack of evidence regarding recovery-oriented inpatient care. So it's unclear how the principles of recovery-oriented care might apply in an inpatient setting. And as all of you are familiar, inpatient care has some significant differences in terms of how it works and the priorities. So within that context, we'll say the Veterans Health Administration, the VA, which gets a lot of press, much of it negative, but you should also know that the VA is the largest integrated healthcare network within the United States. And it's had a really consistent mission to support recovery-oriented and evidence-based mental health care across its national presence. That includes in September of 2013, there was a VA-wide distribution of a new inpatient mental health handbook that, amongst other things, mandated recovery-oriented inpatient care. In conjunction with that, there was a recovery services toolkit that was aimed at helping sites to support recovery-oriented care at their own inpatient units, including an inpatient recovery checklist, which I'll come back to in a little bit. Despite these great efforts, there hadn't been any systematic assessment of recovery-oriented inpatient care within the VA, which is where our study came in. It was funded, as I said, by VA HSR&D. It was a partnership with the Office of Mental Health and Suicide Prevention and launched in 2017, which is longer ago than I want to admit. And this is a mixed qualitative and quantitative study. And I'll go into the methods a little bit more, like right now. So we recruited 34 VA inpatient units across the country. So these represented every major region of the country. 16 different VISNs are Veteran Integrated Service Networks. So those are geographic regions. Most of them were in urban settings, as most VA medical centers are, but we did have 3 rural sites. Important for context here, so the average length of stay across those units was 8.1 days, which is pretty short and is also pretty representative of the acute care units within our VA system. I think probably a little bit longer than what you'll see in community acute, so your average typical inpatient hospital, but shorter than a lot of state hospitals, at least here in Indiana by a lot. In terms of size, the average size was about 21 beds per unit. So in terms of data sources, so we had a very rigorous data collection process. So for each site who came on board, we would conduct a 2-day site visit in which 1 to up to 3 of the study team would go and observe everything that happened on the inpatient unit, treatment planning meetings, inpatient programming, milieu, talk to veterans on the unit, things of that nature. In addition, we had what we called key informant interviews with staff members, as well as veteran interviews. We looked at administrative data from our VA-wide national database and chart reviews of veterans served by those inpatient units. Those key staff interviews that I talked about, we talked to about 4 per site, and we targeted certain positions within those sites that we thought would be particularly knowledgeable. That included unit nurse managers, as well as medical directors or lead psychiatrists, program coordinators who are in charge of psychosocial programming on the unit, social workers, and local recovery coordinators, which are positions at each VA medical center that are charged with supporting recovery-oriented care at their hospital. Our veteran sample, we got an average of about 5.7 veterans per site, and the veterans that we interviewed were generally representative of the patient population of those sites. We did do intentional oversampling of minoritized veterans. So we had a data integration and scoring process. So we had this mountains of data for each of these sites that we had to somehow put together. We would have raters who were members of our study team, and without going into too much detail, basically everybody had experience as providers, consultants, and researchers and family members within psychiatric rehabilitation and various credentials. Each site would have a primary rater as well as secondary and tertiary raters. The primary rater coordinated the data collection with the site, led the site visit, and ultimately drafted a site summary, which attempted to bring together all of these elements or all of these data sources into one place, and would present these to the full team with at least 4 raters present. And we would just talk about the various elements of recovery-oriented care that I'll outline in a second here until we eventually came to a consensus rating of that site. So I referenced our RAIN scale, or how it is that we're going about assessing recovery-oriented care. Now, as it turns out, this was a bit of a process. The question was where to start, because there's numerous definitions of recovery-oriented care, both generally speaking and also for inpatient. They're oftentimes very general or abstract, more aspirational. They're not operationalized in a way that's easily measured for research purposes. And so kind of how do you know which one to choose? Well, we had this VA checklist, and since this was VA focused, we thought that was a good place to start. It was meant for VA, it was tied to that VA handbook and policy. However, it was just intended for self-assessment, more of a QA check rather than for research purposes. So it had certain limitations. There was sometimes wording wasn't clear. So for instance, one item referenced a periodic reality check. And so I don't know what that means. And so we had to go in and actually kind of flesh out what was really meant by some of these things, as well as there's just things that items that were double barreled. They had more than one aspect of care included in the same item that had to be parsed out. There wasn't enough precision in the rating, so the scores weren't tied to objective ratings that we could reliably put to a given item. So we undertook a process of continuous development. We started with that initial scale, and then after each site, we would have these scoring meetings, and we would do notes on how it is that we went about discussing and kind of figuring out these various elements and what evidence supported and didn't. What do we mean by goal setting, for instance? And we would do periodic reviews of the literature to see if there was anything that better informed us there. And as we were making these revisions, then we would also review these with our partners in the VA Office of Mental Health and Suicide Prevention, and also one of our own inpatient program coordinator to say, hey, does this seem like this matches what is meant by what's seen in reality as this goes. So what we eventually ended up with is a 23-item scale of recovery-oriented inpatient care. Each item is rated from 0 to 2. And you can see the anchors there. This is the one for item number 1. This is goal setting. And we take into account on the rating of that both the quality in which that element is provided. So the quality of the goal setting process, for instance, as well as the consistency with which it is applied to patients on the unit. So it's one thing if you've got this really great process in place, but most veterans don't, or most patients don't actually go through that process. It's really hit or miss as to whether you get that. Or on the other side, you've got this kind of mediocre process, but everybody gets it. So to get the highest rating, you had to have excellent quality and consistency. And importantly, whenever possible, we really fleshed out the criteria. Where were the behaviorally observable processes and procedures that we were looking for in order to go into rating those items? Then we took all of these data at the end of this and conducted a confirmatory factor analysis. And we compared a 1 factor, which would say there is just one measure. This is a measure of one thing, which is recovery-oriented care, versus a 4-factor solution. We made some modifications based on some of the psychometric data that we received and did a revised 4-factor solution that overall had the fit indices were in the good range. And internal consistency was also good. So all in all, I think you can take away from this that we were on the road. We've got a pretty good scale, but there's definitely refinement still left to be done. So what are those groups? What are those subscales, those 4 groups? So generally speaking, it's inpatient treatment planning, as you can see in the left here. That starts with goal setting, a written treatment plan focused on those goals, and a shared decision-making process that takes the goals and the veteran's preferences and the family member's preferences and input and turns those into the treatment for that particular patient. That then kind of integrates with an outpatient treatment planning process that is focused on discharge. To where is that veteran going to be discharged and receiving their outpatient care? How does that fit into the work that they've been doing on the inpatient unit and things of that nature? And all of those supported by recovery-oriented milieu and some solid group programming. And there's multiple items under each of these subscales, and I'll go into those in just a second. So let's talk about the penetration of recovery-oriented inpatient care across these 34 sites that we looked at. What's commonly implemented versus what is lacking. So we'll start with some of the, well, actually, we start with the bad news, honestly. So inpatient treatment planning, these set of items, we saw the most deficits. You can see the red. Red indicates that the average score for sites was in the not implemented range. So on average, and you can also see the frequencies of sites scoring 0, 0.51, et cetera, the number and percentages there as well. So as you can see, very few sites were doing recovery-oriented goal setting. Treatment plans were generally not recovery, or the written treatment plans were generally not recovery-oriented. Serious deficits in shared decision-making for medication management and for the inpatient treatment plan on the unit. More okay looking numbers when we talk about outpatient treatment planning. So for instance, shared decision-making around the outpatient treatment to which the veteran would be discharged was in the implemented range, although kind of toward the middle. And outpatient care coordination was generally pretty good. Least restrictive discharge. So here we're looking at our units attempting to discharge the patient to the least restrictive environment that's appropriate for that patient. So If they're, for instance, not relying solely on discharging to residential homes, but rather seeing, is there outpatient supports that can support the veteran living in the community? Group programming, again, pretty midline to better than midline average scores here. This looks at the sufficiency of not only the volume of the group programming, how many groups are offered on the unit, but also the variety of those groups. Do they cover multiple topics? And are they of good quality? And do they support patients actually going to these groups versus sometimes getting in the way of, or pulling patients out regularly from groups or not allowing them to happen, things of this nature. Finally, the milieu also looked pretty good in terms of warm and inviting units, autonomy promoting environments. So these are environments in which patients are allowed to do what they would normally be allowed to do unless there is a significant safety concern to do otherwise. That's how I would describe that. And also, are there respectful and therapeutic interactions between the staff and patients, be nursing staff, doctors, whomever. And here are the other items. These are ones that didn't fit well statistically within our other subscales. That includes integrating physical health, which actually units did a really good job of doing that, as well as suicide prevention, which has been a very major emphasis for the VA for some years now. Very high levels of appropriate focus there. Notable deficit, though, is on individual evidence-based psychotherapy. Although this is explicitly called for, very few units, as you can see, were offering individual therapy at all. So in summary, I'd say there's been moderate penetration of outpatient treatment planning, milieu, and group programming, whereas individual treatment planning and individual therapy are both significantly lacking in the sites that we examined. So, of course, we love to see whether these things we measure are actually linked with outcomes of interest. And so we looked at the association between recovery-oriented care and patient outcomes. So to do this, we focused on those same 34 sites. We pulled administrative data for all admissions to those sites for the 6 months prior to our study visit. Now, the reason for this was there was some concern that if we did it concurrently with or even prospectively to our site visits, that our site visits themselves might have an effect on units. So us coming in, looking at them, giving them their ratings and this sort of thing might change their behavior. And so that what we would actually be seeing was more of an effect of our magical site visits that will cure all of their ails. You can tell I have some skepticism of that, but I hear the concern. Nonetheless, pulling all of those admissions, we pulled 10,109 unique veterans across those 34 sites. Our primary outcome was 30-day readmission, which we defined as either an inpatient or emergency department admission with a primary diagnosis of a mental health condition. And this was pulled from our corporate data warehouse, which is the VA's giant administrative and clinical data repository. And we use generalized linear mixed effects to examine the relationship between the facility level or unit level range scores with patient readmission rates. And we covaried for patient level covariates such as diagnosis and demographics. And the results get a sad face because when looking at the overall mean range score, it was not associated with the odds of readmission. And looking at the subscale scores together, again, not associated with readmission. Now, looking at some exploratory analysis, doing what many good researchers would do, we went on a little bit of a principled fishing expedition in which we looked at the individual items to see perhaps there's some action that's happening at the item level that we've missed with these previous analyses. And so we entered each item separately into its own little model and then retained the items that were associated with readmission at least p less than 0.1. Then we put those together into their own subscale, and then we did find some success. So as you can see with these model estimates here in this table, so to not gloss over, I guess, an important factor here is that there were numerous veteran or patient level factors that were strongly, if oftentimes more strongly associated with readmission. Not surprising, of course, is the number of prior outpatient clinic, or excuse me, prior hospitalizations and ED visits. Not surprising at all there. But also people with substance use disorders and people with personality disorders were more likely to be readmitted. People living in rural locations were less likely to be readmitted. There's multiple reasons for that, but one is likely just artifactual in that, so because VA emergency departments are generally located in urban areas, oftentimes rural veterans will present at EDs that are closer to them in their regional hospital or whatever, rather than going all the way to the city to get to the VA. So we may have just not captured emergency department visits. To be clear, all of our data was taken just from VA. We did not capture any community data on this. But despite all that, our empirical range subscale was still associated with such that higher scores on it were associated with less readmission. And the items that made it into this empirical scale included that individual evidence-based psychotherapies, sufficient volume of group programming, as well as high quality group programming, and multiple disciplines represented. And multiple disciplines represented on the team is misleading for our data because there was very little variation. The primary difference between high and low on that was whether or not there was a psychologist assigned to that treatment team. All the other disciplines, so psychiatrist, nursing, social work, were almost universally represented. So there was no variance there. The only thing that would vary from site to site was a psychologist. And so units with a psychologist were more likely to, had lower readmission rates. As a psychologist myself, I say, well, of course. All right, so summary and conclusions from that aim. I'd say there's a tentative association between certain elements of recovery-oriented care and readmission. Patient factors, not surprisingly, are strongly associated with that patient's likelihood of being readmitted. Therapeutic services were associated with less readmission. And this is consistent with previous research by our own group, as well as by others that have seen the same association. So it seems like there's a growing signal here that these inpatient therapeutic services might be associated with less relapse. But I do want to note important limitations here. So first of all, recovery-oriented care, readmission is not necessarily the primary aim of recovery-oriented care. That's not the be-all, end-all of what we're working toward. So the degree to which this is the appropriate outcome is questionable. We chose this because it was one that is kind of inherently of value to our healthcare system and also to veterans. They don't want to go back in a hospital after they've just been there. But nonetheless, there's probably more proximal outcomes that could be useful. I would note that there's variability lacking on a lot of the elements. So there were some that just had ceiling effects or floor effects such that we just, either everybody was doing it well or everybody was doing it terrible. And so for that reason, another future research should definitely test these effects on increasing recovery-oriented care on more recovery-oriented outcomes, and should also expand beyond VA. So the final aim was looking at the implementation of recovery-oriented care. We wanted to systematically examine the factors affecting inpatient treatment planning. So we focused specifically on the inpatient treatment planning subscale for these analyses. And our reason for this was we had to make choices. The variability or the complexity of, our original thinking was to go, okay, let's say recovery-oriented units versus non-recovery-oriented units, but there was so much variability in terms of ones that were relatively high and what they were doing well in, that it just became too complex and too muddied. So we said, okay, let's focus simply on inpatient treatment planning, because we feel like philosophically that's central to the inpatient recovery-oriented care. So it's kind of hard for me to track the chat.
I'll say, Alan, if you're okay with a question,
Yeah.
Tom was curious about what outcomes would you like to study?
Yes. Yeah, thanks, Tom. I think definitely patient-reported outcomes, including outcomes regarding recovery. There's various recovery scales that would be interesting to measure, as well as satisfaction with services is relevant. Patient activation using the PAM or something like that. I think those sorts of things would be more directly applicable to what we should expect the effects of these to be.
Thank you.
All right, yeah, and please feel free to interrupt with questions, and also I'm hoping we can have questions and discussion at the end. Okay, so yeah, so this is back to the implementation aim and why we focused on inpatient treatment planning. So just to round that out, it was also the lowest overall. So that was the subscale with all the red items, remember. So we decided to compare high versus low sites on inpatient treatment planning as defined by 1 standard deviation above or below the mean, which meant that we had 8 high sites and 5 low sites. We analyzed their site summaries primarily using emergent thematic analysis, but we also went back to primary data, so transcripts from interviews and site observation notes and things like that whenever it was called for, whenever we had a question or we were looking for a quote to particularly exemplify something. And we identified 11 themes across sites, but 5 of those themes differentiated in some meaningful way the high sites versus low sites, which means the other 6 were common across sites. So those you can see here. All right, so a little bit of a busy slide, but I'm going to walk you through it, and hopefully this goes well. So in red, we see universal themes, as in they were common across high and low sites, whereas the white ones are more specific or are differentiators. So for instance, acute focus. So across units, almost everybody talked about that the focus of their unit, the philosophy of their unit is on acute stabilization. That's what our unit is for, as an acute inpatient unit. We're trying to get people stabilized out the door. What differentiated the high sites from the low sites is that even within this acute setting, the high sites had a focus on building rapport with the patients and using that rapport and getting to know the person as a person to drive treatment planning. So here's an exemplary quote. One respondent said, "Every single day we meet with each individual veteran. We talk about really everything that they're bringing to the table and what they want to work on. So every day we try to adjust the treatment." So this also is involved in the goal setting process. I want to say that everybody talked about goals. I mean, we talk about goals, we set goals, we have goals. And almost everybody talked about those goals in terms of short-term clinical goals. That includes things like, well, getting their depression under control, getting their medication worked out, things of that nature. And that was including at the low sites. All right. So everybody, or at the high sites. So everybody agrees we've got these short-term clinical goals. What differentiated high sites was that there was a process in place for actually eliciting recovery-oriented goals as well. So getting to know the person, it was really rooted in this rapport that we've described in the previous step, and deriving from that more recovery-oriented goals, in addition to these short-term goals. So not surprisingly and appropriately, prescribers, we found, drive the medication decisions. They're the key staff person for all sites. High scoring sites differed in that the prescriber wasn't the only voice. So as you can see, this quote from a psychiatrist at a low recovery-oriented site, who, by the way, described himself as very recovery-oriented, said, "The final decision will be mine in directing the patient to choose the right medication." And I love that language, in directing the patient to choose the right medication. So the patient is choosing, they're just telling them which one's the right choice. In contrast, prescribers at the high scoring sites invited input from the veterans, and at the best sites provided options, talked through the pros and cons of those options, and engaged in a process of shared decision making with the patient, and also respected others, family members and other staff people's contributions to that discussion. I see that there is something in the chat.
Oh, that was just me, Alan, reacting to that statement by the psychiatrist. I said, ouch.
Yep. I practiced my poker face during this project. Yes. So finally, on the group therapy, this one is interesting to me. So there was a theme in which group therapeutic programming was seen as synonymous with recovery-oriented inpatient care. So much so that we would ask, tell me about how, does your unit provide recovery-oriented inpatient care? And very often we would hear, oh, yes, we have lots of groups. Period. End of paragraph, end of story. And we would have to really push people about, well, these other aspects of recovery-oriented care. Interestingly, at high sites, at low sites, there was really no discussion of why. Why do we have group programming? What's that supposed to do? And when it did come up, it was, first of all, they were oftentimes talking about how they wish that the groups were mandated, that they were required, that patients wouldn't have a choice as to whether they go to them or not. Why? Well, because that's the way they've seen it in the community, and that's the way it should be. They should go. And the only other reasons were more extrinsic reasons, like, well, if they go to a residential program, they're going to be required to go, so they should just get used to it now. Versus the high scoring sites talked about intrinsic value to group programming. So for instance, one person said, well, it gives a chance to try them out and see what treatments work for you. There you can see it's the group is actually doing something in and of itself. Other low sites would talk about, well, they're sleeping too much, so tell them to go to group. No value in group. They could be going to watch TV or play Yahtzee, but they should be doing something, versus that group actually having meaning, and that meaning tying to recovery-oriented care. So kind of trying to tie some things together, and I'm good on time here. So Our RAIN scale, I believe, is a promising tool for operationalizing and measuring recovery-oriented care. I would say that it's consistent with literature. There's a robust body of literature from various perspectives, including patients who have been on inpatient units and how they would describe what's useful and what's recovery-oriented, as well as provider perspectives on recovery-oriented care, and also efforts within various states and hospital systems to implement recovery-oriented care. Our scale is it all is very consistent with how they describe it in various ways. I hope it's actually more comprehensive than any one of those. But and I think very importantly, it starts to put some meat on the bones of how do we actually know it when we see it? But it definitely has a ways to go. It needs additional refinement, particularly outside of the VA. The VA is a pretty unique microcosm in and of itself. We have, whereas other places don't necessarily have a inpatient handbook or that defines in a certain way what it is that should be required. We do. So there's a certain homogeneity there. So also there seems to be this growing support for therapeutic programming, reducing relapse following discharge. That's important. It's interesting. Definitely leads credence to one of the more popular aspects of recovery-oriented care. But we need experimental data. People self-select whether they attend group or not, at least in our data. And so we need more data, for instance, where we're manipulating the level of group programming that's available on a unit, or some other such sort of data that would really get at that causation a little bit more cleanly. And again, as I said before, data on other more recovery-oriented outcomes would be appropriate. And finally, regarding the implementation, I would say that high and low sites can differ in subtle ways. You talk to people at a high and a low site, and both of them can talk goals, recovery-oriented groups, and say these words. But it's when you start digging in a little bit and start listening to the nuance of how they're describing what it is that they're doing and why they're doing it, is when you can start seeing the differentiation. But we really need more data on how it is that we can effectively support recovery-oriented care on inpatient units. As I alluded to before, it really is a tough nut to crack. There are very important other pressing concerns for inpatient units, not least of which is safety, both of staff and of the patients themselves. And patients in these acute units, they want to get out. They oftentimes they're wanting to get done whatever it is that they came in to do, and get out and forget that this ever happened. And so all of that can create a very challenging place to do meaningful recovery into therapeutic work, not to mention staffing concerns and things like that. So we really need to know how can we make this feasible for staff and patients. And I just end here with the citations. Here's the 4 papers that we've published off of this data so far, and they also have some other good references in there. And at that point in time, I just want to say that's it. We have plenty of time for discussion and questions, so I'd like to open up the floor.
So Tom has another question, and he's asking, RAIN measures recovery-oriented care or inpatient recovery-oriented care?
Inpatient recovery-oriented care. Yeah, it is specific to acute inpatient care.
Thank you. Do we have any other questions for Dr. McGuire? Tom again, he's good at this. He asked, was the length of stay too short?
So, well, that's like asking, I don't know. So there is some signal to a longer length of stay being associated with less chance of relapse. Now, I think that needs to be examined at the unit level and at the veteran level, obviously starting at the patient level. Sometimes patients would be rushed out the door before well, let me give you an example. So one of the sites who is kind of nationally recognized, sites that other places go to kind of see how they do their recovery-oriented care. Their program coordinator said to me, like, and their length of stay was longer. And they said, look, this may be the one shot that we have with this patient. And so we want to get everything that they need done during this stay and get them set up for success. Now, with that said, I wouldn't say that just because you do a longer length of stay, you're going to have better care. And some of the longest stays that we saw for units wasn't because they were making sure they get all the services they need. It was simply because there was just no place for them to discharge. And so they were hanging out.
Yeah. We have another question. Margaret asks, what is Dr. McGuire's educated hunch about the most effective single change treatment teams can implement to support recovery? Wow, that's a big question.
Changed. Well, okay, I'm going to answer it this way. In an ideal world, I would say it's true and meaningful integration of the patient with their treatment plan. That said, that's sometimes can be teaching a fish how to walk. Not for the patient, but for the staff. Because when you don't get it, you just don't get it sometimes. And the power structures in the units that I saw were pretty fixed. Mm-hmm. And if the person at the top of the totem pole didn't get it, that wasn't going to happen. Group programming can be done in a more circumscribed fashion. You can have a champion. You can have a social worker who's passionate about getting group programming set up. And if they can find the staffing, you can still make that happen despite the fact that the person at the top of the totem pole is like, yeah, whatever. Yeah, you should go to group so that you're not sleeping in your room. Whatever. I don't get it. Whatever. So I guess that's kind of two answers, but I'm still taking it.
We'll accept it for now.
Thank you.
We'll circle back in a year or so. So Helen asks, is a treatment plan with the VA linked to insurance or payment for services?
Yeah. So it is, we have, we're JCO accredited. So billing within VA. So we do, depending on I don't want to get too in the weeds here, but veterans have various payment sources for their care. But one of those is private insurance, and also we accept Medicare, Medicaid, all of those sources. And so, our treatment plans have to meet the same criteria for medical necessity as community treatment plans. I think that's probably where you're getting at.
Probably. Tom?
I jumped on because I have an involved question. How's that? My team is doing a study on CRIPA lawsuits. That's the Civil Rights for Institutionalized Persons Act. It's what allows the federal government standing to sue states, particularly state hospitals. And it's early days in the study, but we're looking at about 30 finding letters or 30 pre-lawsuits. And one of the themes seems to be a lack of individual treatment, which kind of makes sense because they're in a large institution. I'm just curious your thoughts on the fact that states are getting sued for not providing individual treatment, and how does it square with what you see with RAIN?
tell me more about what is meant by individual treatment in this case.
So to your point, some of these letters stem from the mid to late 80s, but they describe that the treatment plans are indistinguishable, as are the prescribed treatments are indistinguishable patient to patient. Sometimes even the reason the person's in the hospital is not reflected on the treatment plan. And I think anyone that's seen New Jersey state psychiatric hospitals might suspect some of that's happening. I hope not. Maybe it's not. I don't know.
Yeah, 100%, Tom. So in addition to this study, I did another study that was focused on written treatment plans. And well, first of all, I mean, as a practicing psychologist myself, I can tell you that, I mean, it does just feel like a paperwork burden, right? It seems so hard to make that a meaningful contract between you and the patient and right. Still meet these medical necessity. It's a mess. But yeah, definitely in terms of the written plan, even at good sites, the written plan just had nothing to do whatsoever with anything that we were seeing happening on the unit. I mean, it did. So that doesn't surprise me at all. Definitely many of the units, most of the units, I would say, I mean, there's kind of a guided tour, and in some places that was a good guided tour. I mean, they had quality programming, but it's like, this is what we've got. And that's where you see all those red items on the inpatient treatment planning items, is that I mean, I'm not sure I could think of a single unit where there was a process by which, you know, when I come on the unit, somebody's sitting down with me and saying, hey, here's what we've got. Here's what you can get on the unit. Tell me about what you came here for. Let's see if we can put these two things together. Like, that's just not what happens. Yeah.
Did any of the, and I'll shut up after 10 more questions, but so all of these sites are reviewed by JACO and probably Medicaid. I suspect there was no difference between high and low sites and any kind of assessment. In other words, the reviewers are not looking for recovery-oriented interventions, are they?
To my knowledge, no. Now, I will say we didn't have access to their JACO reports or anything like that, but yeah, I mean, I think that, you know, CARF accreditation probably gets at that a little bit more, but that's not an accreditation I think that regularly our acute units are seeking. You know, VA actually has, I mean, if there's one thing that we do, it's, you know, freaking audits. But so hypothetically, the Office of Mental Health and Suicide Prevention is, you know, they're mandating recovery-oriented care and they're reviewing this, but those reviews are once every 3 years, and they cover the entire hospital. So the chances that they're just not, there's just no way they're going to get into the nitty-gritty that we were able to.
Cool, thank you.
Yeah.
Are there any other questions for Alan before we wrap up today? We have about 6 minutes left for questions, discussion.
Alan, is the scale available, and could another group say use that scale?
Absolutely. Yep. I'd be happy to share it with whomever wants to.
Great.
I'm not seeing any more questions at this time. We still have about 6 more minutes left. So if you can get your question in before I finish my spiel here, my goodbye spiel, then we'll get your question in. But if there are no more further questions, we would like to—
I got a question. What's your next step, Alan? Are you moving on, or are you going to continue studying the RAIN scale?
Yeah. So for the time being, I don't have anything going on with this. There were some other aspects of the work I didn't talk about in this presentation. For instance, I looked at my team looked at the disruption of inpatient services due to COVID.
Oh yeah.
And that was interesting So I won't bury the lead. There was a large disruption to inpatient care due to COVID. So we've done that work. We've done some work on the use of electronic health technologies on inpatient units. In terms of going on with the RAIN scale and this sort of stuff, I started writing a proposal, and for various reasons that's gotten paused, but I'm very interested in the use of peer supports and how peers could be used. So VA has a pretty robust peer provider network, and these are professional paid positions within VAs. And so I think they're ideal people to be that person who comes to the veteran when they come onto the unit and say, hey, let me talk to you about what services we have here. Let me talk to you about what it is that you're here for, what brought you here, and let's see if we can put together, a plan for you and follow up on that. And so just getting together with some colleagues, something along that lines. But like I say, it's currently paused. So I'll pretend like that's my next step.
Aspirational step.
Exactly. Yes.
Tom, anything else?
No, why would you ask me?
I would like to have everybody just take a look at the chat box. Jen put a link there for the training evaluation. So if you could take some time either today or tomorrow, there will be an additional email sent out tomorrow to remind folks to fill out that training evaluation. Additionally, with the email, there will be a link to access the training materials for that Dr. McGuire used in this presentation. We do have one question that came in from Margaret. What percentage of your sites were voluntary units?
Great question. So by voluntary unit, so in VA, what that means is that they can accept involuntary admissions. And there was one site that did not accept voluntary or involuntary admissions at the time of our site visit, but they were in the process of transitioning. Just quick anecdote. One of the sites that we were at, it was within the last few years that it had transitioned to a closed unit. So it was previously a place in which veterans could walk on out the door. So yes, that is our context. Now, in terms of the percentage of patients that were on involuntary admission, I can't give you that. Very quickly, I will tell you that it's lower than in the community for sure. And the acuity just writ large, much lower than in community acute units for sure.
Oh.
There are many patients that I saw. I'm like, there's no way this person would have been hospitalized in the community.
Interesting.
Yeah.
Thank you.
Important context there. Well, yeah. Hey, thanks very much for Tom for the invitation and for you guys taking some time to talk about this today. So it was fun. So thanks a lot, guys.
Thank you, Alan.
Thank you. And thank you, everybody, for attending.
And coming back.
Yes. See you next month.
I will log off. So bye, everybody.
Bye.